We are thrilled today to have three experts here to teach us about the Mexican health system and some of the struggles and successes that we have at our border here with Mexico. So we'll start off with Dr. Adan Larez, who is a family physician down in Sonoita, Mexico. He has worked with many of our faculty for quite a while, and we love having him now as an assistant professor of family medicine for Creighton University. And so we welcome Dr. Adan Larez, who will speak to us first, and then I'll introduce the other two speakers after him. So Dr. Larez, please.
Thank you for the introduction. Hello, everyone. It's an honor to speak to you about my country's health system, at least an overview. I'm a general physician by UABC, and I'm practicing in Sonoita. I will start quoting Seneca with the wish for healing has always been half of health. So what about the other half? Let's talk about it. By definition, a health system, according to the World Health Organization, it's been changing through the years, but it's an organization, people, and action whose primary intent is to promote, restore, and maintain health through education, through good alimentation, good treatment or surgical treatment, medicine, etc. And some characteristics of this health system gotta be universal to get access for every citizen to this system, comprehensive to be not just curative, but preventive, equitable, efficient, flexible, and participatory. Some of these characteristics was tested with this COVID-19 pandemic. Another background of the health systems, there is two main models, the Bismarck and the Beveridge. Both of these, they see the health as a human right from Germany and England, Great Britain. They see the health as human right, but the differences beside the time they were created is the funding for these models. And there is another one, the free market, where health is not seen as a human right, it's a business. The Mexican health system is a mixture of these models, and I will explain to you about this mixture. But not just these models, there is another one, the traditional medicine that we still have in a lot of states in Mexico, that sometimes they are harmful more than helpful. And it consists in the prehispanic medicine, in bone healers, herbalists, people called sobadores, that they try to heal fractures with putting a lot of pressure or something like that. And then we see them in hospitals worse than the disease gotta be. And it still has a lot of indigenous or native tribes being treated by witches, which invokes spirits and divine forces to heal their patients. Another historical fact that I want to show you is this little hospital. 5 centuries, was created 5 centuries ago. It's the oldest in all American continent. It was created with the main reason to be created is to heal the wound in battle in the conquerors, in the Mexican conquest against the natives this hospital is called La Purísima Concepción y Jesús Nazareno. It was created by Hernan Cortés with 20 beds for men and 11 beds for women. Remember this hospital because this is still working until these days. It has a church and it has some new infrastructure, but it's still working. From these 5 centuries, there wasn't any change in the Mexican health system until some decades in 1983, where the Constitution started to see the right to health protection to modifying articles in the Constitution. And then they created the General Law of Health in the Article 2, where they explain how the Mexicans need to have access to health protection. Mexican health system is now, in this slide, we can see how it's divided by 3 main components operating in parallel. Is the social health insurance, where it belongs the IMSS, ISSSTE, the state ISSSTEs, Pemex, and armed forces. As we can remember, the Bismarck and Beveridge, this is more Bismarck model. And the Beveridge model, we can see an example on the public health assistance to the now is changing and now is forming the IMSS Bienestar. And the other part, the private sector, they have differences in funding. And the coverage and how they cover people through employee-based schemes. And this is like we can see how is distributed the coverage in the Mexican health system. And the social health insurance, we can see, is providing 42.2% of the coverage to the country, with mainly through the IMSS. And the bigger part is the called popular insurance, then called INSABI, then it was transformed, or it is now transforming to IMSS Bienestar. But as we can see over here, there is the service, this axis is related with the covered services. As we can see, this is more population covered, but with less services than the rest. The social health insurance is the largest social insurance institution. It's governed by a corporative arrangement. And the other, the ISSSTE, they have their own hospitals, their own personnel. They hire nurses, doctors, all the personnel to work in this building, they are completely separate. They are so separate that if you are working in some area as a patient or as a citizen, and then by anything happen in your life, you change to another job. Like if you are working in a private sector, you have the IMSS, and you have all your record, everything, your medicine, everything is given by this institution. But then you get a new job, a federal job. Then everything is in another building, is forgotten, totally forgotten in that building, in that hospital. And now you go to another one, a new one, it's called ISTE. And then all your record, your health, it has to be initiated from zero. But they have big hospitals. And they are organized by primary level, second level, and third level. But these levels are so centralized. Everything is in the central Mexico, something is in the northern Mexico, but some of all this health, this hospital, this third level or specialized hospitals, they are just in the center of Mexico. And even if you have this insurance, is too hard for people to be in this third level, be attending any problem, big problem, because it's too far from your city. And less covered, but with more budget, is the forces armed, like Army, Marines, Navy. They created their own hospitals with their own budget, and the oil company, Petróleos Mexicanos, Pemex, they have big hospitals for just covering their own employees. And the Minister of Health is the main healthcare funder for health services for the people that is not working in any sector, like entrepreneurs, like people that they are selling stuff in the streets. The only place they can go is the public assistance or the Minister of Health. But the federal government, they manage the big hospital where there is a lot of specialty in any neurology, cardiology. There is a lot of technology in these institutions. But the second level is managed by a state. Even if there is a public health assistance, it's hard to explain how it works, because it's not just one level to be attended. And what about the education? We're talking about the Mexican health system and how the patient get medical attention, but how a doctor can be trained in this complex system. Well, you can choose to be in any of this system, the public health assistance, the IMSS, ISTE. Even you can be trained in a residency in Pemex or even in the military. And there is the other sector, the private. where just 8% of the population, they have private health insurance to cover these big hospitals that are also in the center of Mexico. The more oldest hospital is the ABC. They train doctors to have this specialty, and they are a lot of foundation to help people, but more of this hospital, less than 5% of the Mexicans have access to any of these attention, medical attention. This is just representing the more about the private sector. There is big hospital, but they are not the main private hospital, that they are not the main actors, because like I said, in the pandemic, there were little offices on the side of the pharmacies that they represented the fierce barrier to this pandemic. And now it's controversy on this office that are on the side of the pharmacies. As a data, Mexico shows the highest ratio of private to public hospital. And it is some literature says that the private sector is cruel, because one of the most precious good of the human being, it is considered a commodity. To give you a panorama of the size of how is this Mexican health system being offering attention to the population, we can see the number of beds in all the institution, public sector and private sector. These represent almost the same size of beds to take care of people. And now is start to be growing, because with this new government, everything is changing with IMSS Bienestar. This is another similar illustration on how the Mexican health system works. It's divided by public and private. And the public as well is divided by the Minister of Health and the Social Security. And this Social Security is, the funds come from three parts: the government, employers, and the employee. Who are these? There are IMSS, ISSSTE, Pemex, Army, Marines, and the providers are all hospital clinics and clinics from these institutions, but with their own budget, different budget from IMSS and different budget from ISSSTE, etc. And the other model, the Ministry of Health is divided by federal, because they have the Secretary of Health and the state that they have IMSS Oportunidades. It used to be Popular Insurance, then with another government, they changed it with IMSS Oportunidades, and then now it's creating the IMSS Bienestar, that is welfare. Who are the users? Users in the formal sector, workers, their family, and people who used to work in those sectors. And the Ministry of Health, the users are entrepreneurs, informal sector workers, and unemployed people. Also tourists, also migrants that they are just crossing the country, and sometimes they got sick, and they gotta need be attended by these clinics, hospital, and institution. And there is the private sector, that is any individual, they can pay out of the pocket to a private provider, or sometimes they can pay a private insurance to pay the private provider and get access to this sector. The Mexican health system is changing. We can see there is some states, they have more quality in the healthcare access, and mainly in the northern states and the southern states, they have the lowest quality in health and healthcare. Comparing Mexico with other countries, we are just above Brazil in 2016. I will talk to you about my little town, Sonoita, a little bit. We have a population of almost 60,000 people. You remember about the hospital de la Purísima Concepción with 20 beds? Well, we here in Sonoita, we have in IMSS 2 beds, ISTE 1 bed, and IMSS Welfare or Ministry of Health 3 beds. 0 beds in private sector, 0 operating room. And we have this big area to cover any accident or something happened with people crossing the border. There is always to get attention, they gotta be moved to another city. To put you on an example, people who work in Oxo, Ley, they go to this little clinic called IMSS Sonoita. Teachers, doctors, nurses, workers of the road, working for these federal secretaries, they go to the ISTE in Sonoita. The rest of people, as I say, tourists or migrants, the rest of people don't have any insurance. They're gonna be attended in this little clinic. I will talk to you about a scenario. I will introduce you this flower seller, rose seller in the streets. Her name is Maria. She's working every day, but she don't have any employer. So the only option is to get Seguro Popular or Popular Insurance, INSABI or IMSS Welfare in the Ministry of Health. She's 40 years old, some chronic disease like type 2 diabetes, hypertension, and her kidney is already crying for help. So Maria needs to be attended in the urban health center. That is where there is a doctor, nutritionist, and nurses taking care of her. But the doctor told her that she requires hemodialysis every week, but Seguro Popular or IMSS Bienestar doesn't cover it. So she needs a private hemodialysis center where she needs to pay out of the pocket to get this hemodialysis, which is expensive. Now to Maria, the doctor from the health center sent her to a big hospital in the capital of the state, where she got any attention of a specialist, the nephrologist and everything, but it's too far away from her home and work. And they told her that every 3 months she needs to be there to control her diabetes. But Maria cannot do that travel every 3 months. So she began to go to a generic pharmacy. This little character is seen in all the cities in Mexico. It's a private pharmacy with some office with doctors providing care for free and prescribing medicines. And Maria thinks these medicines are better than the one she's getting from the health center. But then Maria got a salary job and a self-service store like OXXO. And with this job, she started to be affiliated with IMSS. Now she started to go to IMSS, and it's called the Preventive Care Model, where she attends, and the nurse also has some tests, and the result is going to be in 2 weeks. And the nurse tells Maria that probably she had diabetes. Of course, she already knew that. But then she requested an appointment by phone and see the family doctor assigned to her, who asked her to wait another 2 weeks and confirm that she has diabetes. Maria then began to receive hemodialysis in a private center that have an agreement with IMSS. This is the mixture of the health system where IMSS has some agreement with private clinics. If IMSS cannot provide any attention, they pay to different private sectors, and they give the attention to people with IMSS. But Maria had to travel 2 hours to get this attention, even if for free. In the electronic record, the doctor knew the problem Maria had, but she always encountered different doctors, and she never trusts these new doctors. Every day a new doctor, even if everything is on the record. So she preferred to attend the pharmacy doctor, where she trusts this doctor. Then Maria suffered from a food ulcer, and in that IMSS, they sent it back to the Ministry of Health, to the General Hospital in the capital of the state, where her foot was amputated. A year and a half after getting formal employment at the supermarket, Maria was fired due to a cut in personnel. So she lost her IMSS coverage. Remember what I told about changing jobs, where if you change your insurance, everything starts from zero. Now for Maria, she lost her IMSS coverage and had to be back to the Minister of Health. But Maria knows how to deal with adversity. And she continued going to the pharmacy, doctor, paying out of the pocket for her medicine. She did not continue working because of her health condition and her disability due to her amputation, and she never received a prosthesis. So these are the story of a rose or flower seller dealing in the complex Mexican health system. And this is just an example of what millions of people are dealing with every day.
Yeah, I think that's the question. Is there any employees or government people that help people navigate the different health systems, or are people just on their own?
They are on their own, but there is people in any institution that they help for the new customers or new patients to get all the paperwork to start being attending in that kind of insurance. But they are on their own when they are traveling or they are swimming in this complex system.
Maybe I had one question for you. Which system are you in, or is a physician kind of in multiple of the health systems, or are you just one?
That's a very good question, because some of doctors, we can work as private practitioners, we can work as in the morning, for example, we can go to IMSS and if I go to IMSS, I have that insurance. If I working in the Minister of Health, I'm a federal worker, so my insurance is gonna be for Eastern. So it's complex, but most of doctors, we need to have private insurance.
Okay, thank you very much. And maybe we'll have some time at the end where we can have some more questions. But right now, I'd like to introduce our two visitors from the Keno Border Initiative, the Executive Director, Joanna Williams, who took over for, I think, for Father Sean Carroll of the Society of Jesus. And then we have Dr. Yazmin Madrigal Moran, who's the physician at the clinic at the Keno Border Initiative. Jason Bestie and I got to go down and visit. What an incredible center this is. They have social workers, they have lawyers, they have a psychologist, they have a physician, they feed people at a cafeteria there, they have little apartments for people to stay. And these are people who are kind of in limbo. I got to sit in the waiting room and visit with several of these people and just kind of hear their stories, but they're waiting to see if they can get the paperwork they need to come into the United States, or many of them have been deported and have nowhere to go. So they're just doing an incredible work. And we got to go and see Dr. Madrigal in her little clinic there, taking care of people. We are so excited. We immediately did our best to get her a faculty appointment so our students can go work with her, because she's just doing an awesome work down there. And we're so impressed with the organization, the leadership there from Joanna. So we'll get to hear from them now and tell us a little bit about the Keno Border Initiative.
Beautiful. Thank you so much, Randy. Thanks for welcoming us here. I can skip the first slide because Randy already explained everything about Keno Border Initiative. We're a fellow Jesuit organization. We exist binationally, so we actually exist as two legal entities, but operate as a single entity because we believe that the best way to do work at the border is to do it binationally. And one of our values is holistic accompaniment. So that's what underlies all of what Randy just described of direct humanitarian assistance, social work, psychology, all of that. People were people before they became migrants. And so the holistic accompaniment is about kind of trying to recover that. So we served about 240,000 meals last year, sheltered about 2,000 people. Dr. Yazmin and all of her volunteers saw nearly 2,000 people in the clinic over the course of the year. So it's quite an undertaking in this little building. But we don't just do holistic accompaniment. We really want to become a museum one day. We would love to shut down. And in order to do that, we need to do education and advocacy. So really touch hearts and minds in Mexico and in the United States, and also change policy, because the reason that people have to come to us is because of US immigration policy and because of the failings of the Mexican government. So this education and advocacy work we do is towards the goal of one day not having a need to have our shelter and to have our center. So just to give you a snapshot of, Dr. Adan mentioned migrants and how they access care. I just wanted to give a quick snapshot of who it is that we're seeing. This is really important to remember. As Dr. Yazmin talks about obstacles to care, 70% of the people that we're seeing are from Mexico. So they're actually in their country of origin. They're not from the state of Sonora, which is where we're located. A lot of them are from Guerrero or Michoacan, which is further south. But a big portion of our population are in their country of origin and should have access to certain rights as Mexican nationals that they're not getting access to. This is just from January to April. We've seen a big uptick in Venezuelans at the border. So that's the second largest population we're serving. It used to be much more common for us to see Guatemalans and Hondurans than Venezuelans, but the dynamics of migration are changing and will change tomorrow and they'll change the next day. But in the other graph is the mode of arrival. So 72% of the people that we're receiving have just come up from the south and then gotten stranded at the border. It used to be that 70% of our new arrivals were people who had been deported. And I'll talk a little bit about why that shift is. But a quarter of the people that we're serving have tried to cross the desert. So in that map that Adan showed, many of them actually close to Sonoita, they're detained by US Border Patrol and then they're deported to Nogales, Mexico. People are not from Nogales, Mexico. The vast majority of people deported to Nogales, Mexico are from southern Mexico, from Venezuela, from Guatemala. And so they come to us thinking, well, what is my next step at this point? And about a third of the people that we serve are minors under the age of 18. And then obviously you can see that a lot of people are in that youth age demographic over 18. What's really striking to me is how people's decision to migrate has changed over the years. So in 2016, we saw about 70% of the people that we were receiving said that they were coming primarily for economic reasons. So they were coming to give a better life to their kids, to earn more money, to be able to send it back home and build a house. Now in 2022, 75% of the people that we're receiving say that violence is their primary reason of migration. So we've really seen a shift in people's level of insecurity in the region, both in southern Mexico as well as in other countries south of there. And we talk a lot about reasons, why people leave. We don't talk a lot about why people really would rather stay, which was something that really struck me about Walter. This is Walter's photo, but Walter's from Honduras, and it was fascinating for me to talk to him to say, I loved my small town in Honduras. I loved the trips to the beach that I could do with my family. I loved our weekend parties. I loved just spending time with my family, both my nuclear family and my extended family, until the pandemic hit and he lost his job. And then the hurricane hit his town and he lost his house. And then when they moved to another geography, then they were targeted by the gangs because they weren't from around there. And they got caught up in that conflict. And so when we talk about reasons for people to leave, I think it's really important for us to always remember that there's reasons that people want to stay. And it's after multiple waves of experiences that people end up like Walter and have to come to Nogales, Mexico. And so they come to Nogales, Mexico, many of them hoping, somehow my clicker's not working anymore. Can you click on the screen somewhere? Many of them hoping that the United States will offer them protection and safety and maybe the life that they're not able to have. There we go, perfect. And what they encounter are what I would put under the general title of policies of exclusion. I've been at the border for 8 years full-time, 12 years since I first came to KBI. I've seen a lot of iterations of what this looks like. What this looks like is had changed at 9 a.m. today, and is going to change at 11:59 p.m. tomorrow. But basically, it's the general strategy of the US government, say if we can only make people's lives more difficult, then they won't come and they won't migrate. And so what that means is that more people try to go out into more rural areas of the desert, like Sonoita, and thousands of people have died here in our Arizona desert because of that. This is the cross of one man where his remains were found. Many people come close to dying and are deported very dehydrated, and that's something that Yazmin works with, that she can speak in more detail about. And people don't have opportunities to seek legal protection from the US government under the asylum system. And again, there's a whole alphabet soup of policies that have limited this access. Right now, we're under what's called Title 42, which closes the border to uses the public health emergency as a pretext to close the border. That public health emergency is ending at 11:59 p.m. tomorrow. So Title 42 also will end. But while I was driving up from up here to Phoenix this morning is when the Biden administration announced a new regulation that will mean that those Venezuelans that are that 0.25% of people that we're seeing, it will become much more difficult for them to access the asylum process. And I can get into the nitty-gritty policy weeds of what that is, but just so you're aware, it's, you know, when you see in the headlines of the newspaper, Title 42 is ending, the border's opening up, it's not actually true to the experience of what we're going to see on Friday morning. And we're likely to see more and more people who are deported who Nogales is going to be the end of the road for them because they no longer have access to any options in the US. So that's the context that strands people then in Nogales, and they have to make a precarious life in what I would call a situation of medium-term displacement. So people continue to face insecurity. This is Guadalupe and her family, who were stranded in Nogales for over 9 months, and they were targeted by organized crime on multiple instances. There was a time when the only place that they could afford to rent was right along the wall, which is the area that's most controlled by organized crime and the cartel. And so her kids just didn't go outside for anything. She would come and get them food from the Kino Aid Center and would bring it back to them, but she wouldn't let her kids outside because she was afraid that her 2 sons were going to be recruited by the organized crime groups and forced to work for them as lookouts or in other roles. And many of the people who are renting in inadequate rooms. So this is a picture of one mother's room. Oftentimes, for example, the other day I ran into 2 families, one from Guatemala and one from Veracruz. And the moms were renting together, so they'd pitched in together so that it would be a little cheaper. And it was about the size of that table over there was the size of their room, and they had the 2 moms and 4 kids between the 2 of them that were sleeping on the floor. They didn't have mattresses, but they had like sleeping pads basically. And then they're in Nogales waiting, trying to figure out their next options and experiencing a variety of health events along the way. So kind of against that backdrop and perspective, I wanted to pass the microphone to Yazmin so that she can talk in more detail about what is it like to be a doctor in this context? What is it like to treat those people on the white space of the graph that Adan showed us that aren't getting access to care and aren't being covered by the system? So please join me in welcoming Yazmin.
Muchas gracias. Hello, everyone. It's a pleasure and honor to be here with you. My name is Dr. Yazmin Madrigal. I'm Mexican, I'm mother, I'm wife, and I am currently the medical coordinator at Kinover Initiative. In my line of work, I am in charge of saying all the situations related to health the migrants are going through without doubt. This has been one of the most complicated and exciting experiences that I have been through during my professional life. Allow me to explain a little about how our health system works in Mexico. The system is composed of two sectors, the private and the public one. Although access health is a human right, unfortunately for two who want to access the public and free system must be unaffiliated with Social Security through an employer. That is, they must have a formal job under Mexico law. Otherwise, that public health rights becomes private because you must pay to access general and specialized medical care. Unfortunately, for several years in Mexico, we have been going through a strong crisis in terms of access to our civic rights. On the one hand, there is a general ignorance of our rights and how we can demand them end. On the other hand, we have a corrupt and insufficient system where there really is no supply of what is necessary to survive and where the authorities and officials dissociate themselves from any responsibility. So we have been pushed to find these connections to be able to provide patients with the necessary requirements in order to be well served and avoid service being denied, as it happened in several occasions. We had a case where a pregnant woman went to the hospital because she was starting to have contractions. The hospital did a medical assessment and determined that she was going to have her baby soon. But the hospital handed her a note with materials that the hospital needed in order to perform the medical procedure. This is one of the notes in a piece of paper with a handwritten note asking the patient to go buy the materials the hospital needs. In this case, the hospital asked the migrant woman to buy umbilical cord and scissors. Now, something that I have learned during this month that I have worked at Kino is that although the health system in Mexico is poor, we are also witnessing a phenomenon of insecurity at the national level that ends worsening the well-being of the people. I think it is important to me to share that from my personal experience, I have been impacted by the stories that I hear daily in my medical office. Every day, I have gotten to know migrants that have left home in search of better quality of life, are in the search of justice and security. They are people like any of you who have decided to live because they know that by not doing so, it put their lives in danger. However, also during these months, I have encountered situations that I will witness, and I have give stories to people who want never gone to medical consultations throughout with lives. This is important, highlights the people have not gone to the doctor, not because they not want to, or because they do not know that there is medical attention available, but my patients have lived excluded and excluded, sorry. And migrants, my marginalities for living to towns where organized crimes decide whether there can be health day or not. For example, where they decide whether they can travel along the roads to get to the hospital or not. In fact, it seems important to mention that the main causes of mortality in Mexico are due diseases whose complications can be preventable, and even on many occasions, people die without medical diagnosis. In this way, the work I do together with the volunteers at the Kino Clinic consists in welcoming people, in attending to them in a humane way, to return to them the desire to want to take care of themselves and live healthy lives. And above all, we work with a human rights approachment in mind, where I get to hear with the stories, victims from them. We identify symptoms, we create medical files and explain to them in detail. From beginning to end, what they have, why it hurts them, why it is important that they continue to have medical checkups, and we explain why medical is a human right and how they can learn to demand it. Some of these people something speak indigenous language, and it is hard to them to understand and native to medical world. How will you feel as doctor to hear that 70% of migrants have never received health care? How will you raise your voice for people who are migrating? From Kino, we know that those who want the responsibility of providing health service is the Mexican state. And we know in advance that having a medical clinic in Kino, or even having an organizations like Kino, only highlights a little the harsh really that migrants are going through. However, we also believe that this effort return hope and strengthened our community. In this way, we offer humanitarian service from a just, dignity, and hospital place. Moreover, our work in the medical area also entails gradually raising awareness among these public health institutions. It is a difficult job, but not impossible, and I am proud to say that little by little, we have management to form alliances even with government institutions in order to provide the quality of life people who need medical attention. Voy a hablarles sobre un caso de un paciente de 43 años de edad de nacionalidad haitiana.
So I'm going to share a little bit with you about the case of one patient who is a 43-year-old male from Haiti.
Este caso, el motivo de consulta fue para realizar una curación de su sexto dedo que se había lastimado en su recorrido por la jungla.
So the motivation, what motivated him to seek medical attention was to have his sixth finger cured because it had been injured while he was in the jungle, while he was crossing through the jungle.
Lo primero que le pregunté fue, ¿tú quieres tener un sexto dedo?
The first thing that I asked him was, do you want to have a sixth finger?
El paciente me dijo que no, que él tenía 43 años yendo a hospitales en diferentes partes del mundo y siempre le decían que su cirugía era muy pequeña para un quirófano o que simplemente era muy difícil quitar un sexto dedo sin hueso.
And he's responded that no, but over his 43 years of life, he tried to seek out medical care in a number of clinics around the world. And every time he was told that his operation was too minor to justify the use of a surgery room, or simply that it wouldn't be possible to to remove his sixth finger that didn't have a bone.
No podía creerlo.
I couldn't believe him.
Gracias a las conexiones que hemos hecho en Kino, yo llamé a ciertas personas encargadas en gobierno y ayudé a que se le diera atención, no nada más para curarlo, sino para quitarle su sexto dedo.
So thanks to the connections that we have in Kino, I reached out to different government institutions, and we were able to help him not just to heal his sixth finger, but also help him to not have a sixth finger anymore.
Surely, thank you. Surely it will continue to be a change for public health to really become free and accessible to all, but we know that it is an effort we're undertaking. Finally, if you are wondering why am I talking about this here with future doctors, why talk about this in the United States? I come to you because these challenges that I have spoken about do not end when you cross the border. I come to you to share my experience and about all so that we remember as health professionals that before any medical procedure, there is a person who needs use. And also because it is in our daily practice to make health service accessible and humane to patients around the world, regardless of their immigration status, race, color, or sex. Today, I come to remind you that in each white coat, there is a young, passionate medical student who decided to study medicine with the design to transform the world in a healthy place for everyone. Health is a component that we all assume here. I want to finish this talk with a phrase that I like very much, and I experience it every day in my work. In books, you will learn about diseases. In the medical consulting room, you will understand the impact as on the life of the patient.
So just to make a little bit more concrete, Yazmin's invitation that maybe it feels distant, maybe it feels like, oh, it's over, oh, what does that have to do with us? There's lots of ways that you can become engaged. Obviously we're a nonprofit, so you could support us because we got to pay Yazmin's salary. You can volunteer at the Kino Border Initiative. That's something that Creighton, Dr. Anna already came down to pave the way for all of you to come down as volunteers. And Randy's also been down and visited, so you can come down and support. Really important to remember what Yazmin said about these are people's experiences in Nogales, Mexico. These might be people that you encounter in your practice here in the United States. So the more that you can understand about their journeys, the better doctor that you can be to them. So we have the Voices of the Border book that I showed on the slide previously, I meant to bring, but left in my car. But you can check it out on our website. We subscribe to our newsletter and hear stories like that of Eva, which I don't have time to tell. And there's also an organization called the Migrant Clinicians Network that looks into best practices for working with the migrant population. And we've contributed to some of their materials and partnered with them on different efforts. So I'd highly recommend checking out the resources that they have. And then allow that knowledge to inform your care for immigrants in the Phoenix area, because maybe they've been people that Yazmin has seen and that have gone through these experiences. And so allow that to shape the way that you treat them and care for them. So thank you so much for being here. And I think we'll have some time for questions soon.
Thank you so much to all three of you. And I love, Yazmin, how you said when you have that white coat on, you have a responsibility. And I think that goes for all of our healthcare workers. We have so many different health sciences here in this building, but also in Omaha, in our Creighton University sites there as well, that can all be of help, right? Physicians and nurses and PT and OT, pharm. There's a lot of different health sciences that can do a lot of good. First question that has already come through, we have several. First question that's already come through is, how do people find KBI? How do they find your Kino facility?
Okay. So there's a couple, it depends on which way they arrive. I talked about the modalities of arrival a little bit ago. The people who are deported, so they're either deported after having lived in the US, they've been in Phoenix or Omaha and are sent back to Nogales, or they just crossed the border. When they're sent back, they're supposed to be received by Mexican authorities, and the Mexican authorities are supposed to tell them that they can come to Kino Border Initiative. I say supposed to because the US government sometimes deports people at 2 a.m. and so there's nobody to receive them. So that then they fall into the second category, which is also relevant for the people from the South, which oftentimes they arrive to the city of Nogales and people just start asking around or asking for help. They might come up to someone on the street and say, hey, can you help me? You know, my kids are hungry. Can you help me? And then we're well known in the Nogales community. And so then they'll get referred, hopefully they will get referred to Kino. And so a lot of the arrivals are due to word of mouth. We are seeing some people too who, you know, with technology and the internet, will look up online, you know, who, if I'm in Nogales and I need help for migrants, and then Kino is the first result. And if you're going to Google that, then it'll show up. And so people have messaged us on Facebook and said, can you provide me with help if I'm in Nogales? And we said, yeah, here's our address, come on over. But I would say word of mouth is the primary, sometimes Mexican government, and a few Facebook arrivals.
Great. A follow-up to that is, what is your capacity like? You said you were doing about 2,000 patients a year, but are you able to take more capacity, or are you needing more help in order to take more patients?
Gracias. Hay ocasiones que tengo una población muy variada. Hay ocasiones que puedo ver hasta 50 pacientes diario y hay veces que solamente miro 5.
It's a pretty variable population. Sometimes there's days when I'll see 50 patients in a day, and sometimes there's days when I'll see 5 patients.
Claramente cuando son 50 no me alcanza en mi horario laboral, pero nos abastecemos gracias a los voluntarios médicos que tienen experiencia médica y que nos ayudan a atender a más número de personas que realmente necesitan la atención.
Obviously, with 50 patients, I couldn't fit that into a normal workday, but we managed to get through thanks to medical volunteers or volunteers with medical experience who will support in seeing the patients. So yes, we need more help.
And then also another question that came through was, what preparations did KBI need to go through in order to get through the changes that are happening tomorrow? Were there preparations made that you were able to get through in order to feel prepared?
Yeah, that's a great question for an executive director. We've seen it sort of in 3 ways. One of our areas of preparation has just been on information of knowing what are the changes going to be tomorrow, both getting that information from the government and also communicating it out to migrants. So we had plans for how are we going to communicate out this information once we know it. So we, as things have become available, then we've used different channels. So yesterday afternoon, for example, I was, since I couldn't be there in Nogales this morning, I was recording an audio of myself that my staff could play at morning prayer with our latest update. And then tomorrow at 11 a.m. we have our orientation with the lawyers who will talk about some of the changes. So the first pillar was information, because it's so confusing and so variable. And we still don't have all the information of what's going to happen. We have I don't think I can say this publicly. We have some information leaked from some sources that help beyond the public information, but even then, that's a little bit lacking. The second area that we thought about a lot is how flexible can we be in our humanitarian capacity, which I gotta say, I think is one of our strengths at KBI. You know, in summer of 2021, I remember in May, we said we started to see it increases in numbers, and we were serving about 200 people a day, then it was 300, and I asked, or we were serving 200 people a day, and I asked my director of migrant services, how many people can we serve in a day? And he said, I think we max out at 400. And by August, we were serving 900. So there you go. I think we do a good job of really getting down to what's absolutely essential. People need food, clothing, medical care, and we'll scrape. I mean, our psychologist will jump in and serve beans if we need to. Not that people don't need psychology, but they're not going to be very good with a psychologist if they haven't had breakfast first. So we've made plans for how we can flex our services and flex our volunteers to focus on the absolute core. So we're ready to maybe serve 900 people instead of the 300 that we're seeing a day right now. And then the third thing that we've done is more from a staff care perspective of, we're just a team that goes through change a lot. And we wanted to prepare ourselves emotionally and spiritually and create a sense of safety in the change. So we made that the topic of our last staff retreat. We had some time where we could reflect on how God is with us in the changes, share with each other the hope that we felt, and also make an intention about that change. So we all have little rocks that we made an intention of how we're going to live this change. And that spiritual, emotional part, I think, is actually the most important, because that's what allows us to do the first and second parts. Because if we as a staff can have an attitude, which I think we do, is a great joy of working at KBI. If we have as a staff have an attitude of adaptive capacity and this is all possible, and we're, whatever tomorrow brings, then literally whatever tomorrow brings, we'll make it work. We'll see what tomorrow brings.
So you're not only taking care of patients, but you're taking care of each other too. So love it. We're going to take some in-person questions, and then I will read some more off the chat because we do have some more.
Well, first, I want to commend you too for coming up. And my experience when I went down for one day was wonderful. And I feel like I was totally reading Gustavo Gutierrez and Paul Farmer's book, In the Company of the Poor, because that's exactly your approach. Having said that, my question for Yazmin, mi pregunta para ti sería, what do you need in terms of human resources and material resources that we can give you? ¿Qué es lo que tú nos pedirías a nosotros que queremos hacer voluntario y en términos de recursos humanos y materiales? Y tú me lo has dicho a mí, pero sería bueno porque hay doctores en la audiencia. Y qué tipo de horarios para nosotros ir a Nogales te ayudaría.
Pues creo que obviamente el conocimiento de un estudiante de medicina es primordial porque me da más abastecimiento de ver más número de personas. Posterior a eso, de voluntarios médicos, bajo el requerimiento de necesidades médicas, que ya tenemos nuestro grupito en WhatsApp de voluntarios que publican, hacemos una lista semanal de qué cosas ya no tenemos y nos las siguen pidiendo. Si quieres, ve traduciendo ya para que no.
So the support of having, for example, medical students is very helpful because it allows me to extend myself more and have more supply to be able to see patients. And then obviously the medical volunteers. And we have a WhatsApp group amongst the medical volunteers where we share the different things we're requiring.
Creo que posterior a eso nos habían comentado de un equipo de ultrasonografía, el cual aceptaríamos con gusto. sí le daríamos mucho uso realmente y adicional a eso, creo que posterior al incidente que tuvimos con la cirugía que no se pudo realizar, ya llevo mi cautín personal en caso de que llegue alguien con un sexto dedo.
We've been promised ultrasound equipment, which I hope that arrives because we would make a lot of use of that. And then, you know, as a learning from the surgery that we weren't able to do, I also have now I don't know my medical or Spanish or English, cautín. ¿Qué es un cautín? There we go. Cauterization. I don't know what that is in English either. That's why I'm learning from you all. Cauterization equipment to be able to do that, provide that support in the future.
For those doctors who want to go, like I'm not going through Creighton. I just wanted to clarify. I went on my own, and I've been trying to recruit other doctors to go. And one of the questions they ask is about the malpractice insurance, but Joanna very kindly clarified that we're covered under KBI insurance in Mexico, and of course, we still have MICA for those of us who practice in Arizona. So. I think that's a very important question that I got when I tried to recruit my group of volunteers.
Let me just ask Adan the same question. What needs do you have down in Sonoita that you know, medical students, residents, and faculty could help you with?
Yeah, well, right now there is a lot of areas where there can be helpful, but right now we're trying to ask help for the local government, the state government, to create an operating room to this little city. So there is no specific help to this town. We are trying to have the building and then start to have that operating room.
Thank you. And are you already having some students come down and do clinic with you there?
Yes, we already been doing some clinics, but we need to, it cannot be done in Sonoita. We are doing it in Rocky Point, where we get some surgery for like lap choles, hernias, hysterectomies, use that kind of surgeries is very helpful to these needy people.
Would it be helpful to you to have students come down and work with you in your clinic in Sonoita?
Yeah, sure. We can have some students to get some help from them.
So one of the questions on the chat was, what are we doing from Creighton University? What groups do we already have organized, or is somebody putting that together to go down to KBI?
So great question. Thank you. And we do have the Rocky Point Clinic that our students are going to currently. I thought before we did have students going to Sonoita, but maybe we need to reorganize that and have that start to happen. And I know Jason Bestie is getting approval from our vice provost to have this be officially recognized as a Creighton site. Now that we have a Creighton faculty there, we should be able to do the same thing now in a more official way from our students to go and have the experience down in Kino. So I think there's a couple of things we can do. We could offer this as a fourth-year elective for sure, where a fourth-year student could go down and work with you. We could also have it be potentially a 2-week third-year elective, which would be a possibility as well. But then we can have volunteers as first and second years that could start to go down. Now we want to maybe work with you, Yazmin, to see what, we don't want to overwhelm your clinic, right? Because we got a bunch of students, I think, that would really like to go down and be part of what you guys are doing there, because it is incredible. But maybe working together with you to find out what the needs are, and then we could have a list of volunteers that would like to go down.
All right. Another question we've got too is, oh, did you want to talk to that? Okay.
I'm just going to promote Yazmin for a moment because she's a wonderful doctor, but also she's had a couple of volunteers who have been pre-med. So they took a gap year between university and going to medical school, and they've come and volunteered with Yazmin. And I was collecting some staff praise for our retreat so that we could also encourage ourselves with the good job we're doing. And they sent in the most moving comments about what a great teacher Yazmin is, how patient she is with them, how much she inspired them along the journey. So I'm just very grateful for her disposition, not just towards the patients, but I think she's done a great job working with students too.
Absolutely. Thank you. And maybe a question for you, Joanna. Somebody asks, what happens to all the migrants who are denied entry into the US or denied asylum, especially those that are unaccompanied minors?
So it depends on how they were, whether they were denied entry or denied asylum. So right now, a lot of people are being denied entry, but they're not being denied asylum. Their asylum cases haven't been lost yet. So those people could still consider applying for asylum in the US through a phone app that's called CBP One that just changed today too. But basically they have to log onto this app and fill out their information, and then they go into a lottery to see if it's their lucky day and they get an appointment. But if they've been denied, so many of the people who have been denied entry but not asylum make that decision to try again. Those who are denied asylum, then it's a lot of our work of trying to help them think about what's plan B, C, D, and E. So some of those individuals decide to travel elsewhere. We have a little bit of a budget to cover people's travel costs. For example, they might have a family member in Mexico City or in Tijuana or somewhere else that they could travel to and try to work there. And then there's people we accompany who decide to settle in Nogales. Something of one family, for example, that was denied asylum a couple of years ago, and they're not receiving services per se from KBI, but they'll still come by to ask some advice from our social worker, or if the dad is working a factory job, the mom's working in a store, their kids are enrolled in education, and so that's the holistic accompaniment piece, is helping promote local integration. And a lot of our advocacy on the Mexican side, Yazmin already talked about the health access advocacy. We do a lot of advocacy with Mexican authorities to promote access to education, access to housing, access to employment, to give the possibility that somebody might be able to integrate into Nogales in those situations where they decide to stay.
Thank you for